Thank you, Sally, for introducing me, and thank you all for coming, making the journey up tonight. And thank you for those online as well. I'm hoping you're not going to fall asleep during this. It's only about 40 minutes, so try not to. And I'm going to talk you through one of my, well, pet subjects, I suppose, and a little bit about myself as well. So hopefully it's sort of interesting, I hope. This is one of our patients, and they freely shared these images. And this is a really nice picture drawn by one of the children who was the siblings of a child who was in intensive care, to my colleague Lisa, who was the nurse, about what she did in what he saw her doing all day, which I thought was really fun. What is evidence-based practice? So some of you know this really well, I know. Some of you are healthcare professionals, some of you aren't. If you're not, I'll try and explain this. I'm going to ask you to think about what you would expect when you go to visit a doctor, a nurse, a physio, a dietitian, whoever it is that you go to visit. Do you expect them? I imagine, I do, expect them to use their clinical expertise, experience that they've got working in the specialty, working with their patient groups. I expect them to take into account my preferences as a patient, or your child's preferences, or as a parent. And I expect them to use evidence, research evidence, that is, that shows that one treatment or whatever you're going to prescribe or give them is effective. So that's effectively what evidence-based practice is. It's those three things. I'm going to talk that through later on. And just to say, coming up to Christmas, if you work in intensive care, you develop a sort of strange sense of humour, probably, to survive in a specialty this long, because we see things that people aren't supposed to see, and they're pretty horrific sometimes. And so this was, but I thought this was rather amusing, but some people won't. Coming up to Christmas, elf on the shelf for your children, you know. So this was a picture put on Twitter last year by an intensive care nurse who had intubated elf on the shelf with a straw, put a breathing tube down, put various lines in elf and put him on machines. And I thought that was really quite funny, but I imagine it could traumatise your children for many years to come. So just to summarise, that's really what I'm going to talk about tonight, is this is evidence-based practice, using your experience as a nurse, doctor, dietitian, pharmacist, physio, using your experience, taking into account patient and parent wishes, and using best research evidence when it exists. Sometimes it does, sometimes it doesn't, but I'll talk about why you don't use it perhaps. So for the next 40 minutes or so, I'm going to take you into my world. This has been my world, the intensive care unit, for over 30 years now. A number of units, but this is older hay, it doesn't really matter, but this is my world and I'm going to try and take you into that. I'm being overly excited there. So clearly I'm not from these parts, and so this is where I started over here. I've traveled some distance to come to be here, and you can't actually see very clearly in that little thing, which is probably fine because you don't really need to see a picture of me at 5, but so this is where it started, and what you can't see on a very poor photograph, because we had Polaroids in the 1970s, okay, so they popped out things, and the images, the pictures don't last very well. But I blame my grandmother for this entirely. If you can see that, I'm actually dressed as a nurse. I'm holding a baby, and there's loads of babies around the floor there. I don't know what happened to them. But I think my destiny perhaps was sealed by her. So where did it all start? I'm not from here, as I said. I'm from Brisbane, which is the capital of Queensland in Australia. It's a city of around 2 million people, a bit like the same size as Liverpool, but a bit more spread out. It's a beautiful place, and all my family is still there. So how did it all start for me, and how did I get into critical care nursing? So there's a very unattractive picture of me at the start of my career, but nevertheless, I'm university educated. Now in Australia, I trained at this place called the Queensland University of Technology. This was the second year that that nurse education went into higher education for the university sector in this era. And it was a heavily science-based 4-year degree program. So unlike exactly what is happening here, you know, in the UK now, we had 3 years of physiology, pharmacology, we had physics, we had nutritional biochemistry, microbiology, sociology, psychology, and the list goes on. We did have nursing subjects, you'll be pleased to know, 3 each semester. They were taught by nurses, but all the other subjects were taught by discipline-specific people. And at the time, I did not realise the significance of this, and we were taught and examined on physical examination skills. It really didn't mean anything to me at the time. This is what we did, and we were examined. It became clear later on the importance of this. you'll see later on. And we weren't allowed to do specialty areas in the training, the luxury, but we just worked medical, surgical, wards. That's how we trained. We weren't allowed to go to specialty areas. In the final year, at the end of the final year, we were allowed to do a optional 1 week adult ICU placement. So I went to adult ICU. In this hospital is where I did a lot of my training, the Mater, and as soon as I was working with a nurse there, obviously, and we had a patient, he was an adult, a man, that's all I remember. He had sepsis, overwhelming infection and bowel surgery, I think, and he was on a breathing machine. Within 2 hours of being there, I knew this was where I would work forever. There was really no doubt in my mind. And before I'd been there, I didn't know that. I thought maybe I liked neurosurgical wards or something like that. But, halfway, 2 hours into the shift, she had to suction this fellow down the breathing tube, which is a really common thing that we do. But she decided she couldn't teach me how to suction, and so she would teach me how to manually hand ventilate this man. So I managed to do that. If you know these adult baths, they're quite difficult, so if you haven't used them before. And I thought, well, this is amazing. I'm going to work here forever. And because you would really never stop learning, ever. And still, to this day, 30 years on, and I'm sure Jerry and others in the room can tell you that you still learn things every day in this specialty. Of course, there is some routine things like there is, but there's a lot to learn, and it's very interesting. And you have to learn quickly, particularly when you're junior, because the repercussions for the patients are quite bad if you don't learn quickly, pick it up quickly. So when we worked, having worked here, doing a lot of my training based in this placement, in this hospital, when we qualified, as I said, we were university educated. It was the second year that this was happening in the States, so we still had students going through hospitals. And so they didn't think we had enough clinical practice experience to just be qualified. So they made us do a graduate year and work around 3 wards, so like an internship for 12 months. We were paid, but we had to rotate around. We weren't allowed to go to any specialties. Again, the luxury. But anyway, so I had to do that. I didn't really want to, but I had to do it. And then to the day I applied to work in this same hospital, the 10-bed general adult intensive care and the coronary care unit. So I did that for a few months and I loved that. It was a very steep learning curve. I felt like I had an arrhythmia nearly every single day of my shift, with a very high heart rate, and I don't want to collapse. This is how stressful I found it, but it was great. And then I did 6 months of ED, just trauma ED, just to make sure I wasn't, making mistakes, just in case just to be certain. And I liked resus, but I didn't really like the rest of ED, so emergency department. So then I decided this job came up in a specialty hospital called the Prince Charles Hospital. There it is. And it was massive. It had the biggest number of critical care beds in the state. So remember, Australia's got a massive geography. So it's heavily centralised. Cardiac surgery for anyone, be they neonate to 80-year-old, was in this place. There was nowhere else in the state that did it. We also took patients from Papua New Guinea, Fiji, and all the islands. It was massive centralisation. So I was there for 5 years. And I loved it. It was, again, massive learning curve. I thought I knew some stuff about critical care, and then I had to learn cardiac intensive care. But, there was lots of educational available to us. It was free. We had to do it in our own time, and so I took a month off, did the coronary care course. I took another month off the following year and did the pediatric congenital heart disease course. So you could do it, but you have to do it in your own time. Then I did a master's there. It was the first clinical master's in Australia, actually, ideally to prepare nurses to be advanced nurse practitioners. So I did this. It was a specialist clinical master's, and it was good. It was hard work, very hard work, but it was good. So it was in this place really that I learned to nurse not just sick children, but incredibly sick children and babies after heart surgery. We had to learn on the adults first. That sounds lovely, doesn't it? But we did. Guinea pigs. No, we had to learn with the adults first for a year, and then if you were deemed good enough, this is what it was like these days. You were allowed to learn children, being very highly supervised. But as I say, I lasted 5 years here. I absolutely loved it, and I took on management roles and the nurse educator role, and there's another very unflattering picture of me, and look at the monitor at the time. It's like a relic, but that's what it was, children after heart surgery and stuff. And, it was, I really began to, I guess, develop practice and change practice. And there was any of you who've done adult heart surgery, and not many of you may have done that, but it's inconceivable now if I tell anyone that does adult heart surgery that we weren't allowed to extubate these adults, and they did take the breathing tube out. We didn't have any intensive care doctors. They only were looked after by surgeons. The children were looked after by intensive care doctors, but not the adults. So we had to wait until the surgeon came out of the operating room to take the breathing tube out. These operations are 4 to 5 hours long. So this was clearly not ideal. And complications for these adults who are well going into heart surgery are really very low. It was just madness, So I developed this competency and we taught people, and then we did this and it happened. I mean, it just was inconceivable, but people couldn't believe this now, that adults weren't, the breathing tube wasn't taken out of these adults. So then I decided, as I said to you, I did this master's program, and it would prepare you to be really, I suppose, advanced practitioner, although we didn't really have these roles. So I did it because I thought this is interesting, I want to be clinical. And when we came back, of course, there was no role. So I just went back into being a charge nurse, educator, and, so it was a bit of a, I thought, okay, I think I better do something else here now. So I decided I'd move to London. For a couple of years, one of the cardiac surgeons, I blame him, as you always should do, he said, oh, this is the place we all go here, it all does lots of transplants like we do in this place, and you'll love it, it was great, little cottage hospital just outside London. Anyway, so I moved to London. I lived in the UK for a year when I was at school. I went to school in Cardiff for a couple of years. So it's like I hadn't been to the UK. So I took myself off to London. This is, thinking great, and turned up at this hospital, which you'll see the name of in a minute anyway. And it wasn't quite as I'd expected. So I took a staff nurse job, and what became, in Australia, if you could do things, you were allowed to do things, and you had clinical competencies recognised, but it was quite clear that that was not the case in this paediatric intensive care unit, very specialist, only heart surgery and heart-lung transplants. So you weren't allowed to do it. They didn't actually wear caps, but they may as well have, because the mentality was worse than just the cap, actually. And that wasn't exactly the ventilator, but honestly, it could have been. That's what it felt like to me. In this particular first experience of UK, it was like I'd stepped back 20 years, except I had never seen anything like this. And the interesting thing was that, so when patients on a breathing machine, we always have a stethoscope and we listen to chest, because we need to make sure they might need suctioning down the breathing machine. This is normal, okay? And I noticed I had this patient on the first couple of days, no stethoscopes, no around the bed, no stethoscopes at all, none. The doctors had their own around their neck, that's great, but the nurses didn't have any. So I had my own, of course, Littman, got it out of my bag, started listening to the patient's chest. It was not a breathing machine. This is what we should do. This is good practice. This is safe practice. And across the unit, the senior sister screamed down across the unit to me, Lyvonne, nurses do use stethoscopes. What are you doing? So I didn't last very long in this paediatric intensive care unit, as you can imagine. I went to work on the adult ICU for 4 months just to work out what I was going to do, because the adult ICU was completely different, and went somewhere else. So I've been to lots of places, probably more than most English have been, I would suggest. So as I say, I started here, and then after choosing the place, the second place I would work very well, I went to Brompton, which strangely, ironically, the two hospitals have now merged. They could not be further apart in philosophy and practice and ideals, honestly. It was like chalk and cheese. So I moved here. This was an amazing hospital. I was there for many years. Really fantastic cardiac surgical heart surgery and stuff. There's a picture of me. I don't always hate that was Christmas Day, actually. So that's why we dressed up as angels, not making a habit of it or anything. I did a brief stint in King's College London as a lecturer, but really didn't have any practice. We weren't allowed to do practice. We just had to teach. It just didn't feel right with me at all. And I did do some coronary care in there. And then I moved up to Liverpool. I'll talk more about that later. But my partner at the time, now my husband Hugo, who's here, I moved up here and started working in Old Hay and John Moores. And then since then, I've been to a few other places, university, but up to Preston and down to Bristol. That was a difficult commute. And then to Salford, and now I'm here. So I think I've moved around a fair bit. So getting back to the topic, so you don't forget what we're talking about in the first instance, is the critical care unit different? You know, is clinical experience the most important thing guiding what decisions, what treatments patients get in the intensive care unit? Is it the most important thing? And the two arguments I've heard, and honestly, I've said them myself actually over the years, is, look, our patients are complex, you know, decisions have to be made quickly, they're really sick, they're not like sitting on a ward or anything. And the other thing is, well, we don't have any trials or evidence to guide our practice, so we can't use evidence, you know. These are the two common views put forward or arguments put forward. But actually, if you look at the evidence for how many studies, in particular randomized control trials, these are the highest level studies that try and prove one treatment is more effective than another. Other studies are of course highly valuable, but they don't prove that one treatment is more effective than another. So if you look at just the pediatric critical cares trials published over time, I mean, look, when I trained, so you know when that was now, there was no mention of critical care, you know, trials and evidence, because there probably wasn't any, okay, in anything, let alone, you know, or very limited. But actually, and even in my master's, you know, we really didn't get much introduction to evidence-based practice. But, you know, there's been an escalation in trials, really. And I think that argument is less, it's not that it's perfect and we don't have evidence for everything, we do, but it's certainly less of a valid argument than it used to be. And I'll give you an example. So recently, there was I didn't lead this study, but I was on the team. My colleague Ram, who may be on the call, did a randomized control trial of two different types of breathing devices we can use for children. One called high flow and one called CPAP. So both non-invasive, not a breathing tube, and compared one to the other. This was in our patient group, so our population was there. So we had a journal club. And we, as we often do, and Hugh May sometimes runs them, we often, you know, so at the end of the journal club, one of the consultants said, so, to the people who presented and to the people on the call, how are you going to change your practice? And so this was a large study, and it showed that one was better than the other. And this isn't a person, this is random, by the way. So, but yes, and a couple of people said this, you know, I've used X for practice A for teams. I actually think it's better. So, you know, I don't think I'll change my practice. So the question is, why are we wasting £2 million each of a trial of taxpayers' money, because this is NHR funded, if we're not going to change when things are shown to be effective? So what if good research evidence does in fact exist? Firstly, staff at the bedside, or wherever at the bedside, have to be aware of the evidence. They don't know about it, and they're not going to read everything there is published. No one can actually physically do that, but they need to be aware of it in the first instance. And that's why we use things like journal clubs to do that. Then they have to accept the evidence. And it's especially so if it's not what they currently do or think. So I think we have a little bit of selective use of evidence here. We like to say we're evidence-based practice, but that's all great if the evidence or the trials show that the practice we like to do, or we think is better, actually is better. If it's the other way around, then the question is, are people willing to change their practice? I see that less likely. So let's get back a little bit to when I first learned about evidence-based practice. So Ian Bullock, who's on the call, was the first person. He was my boss at Imperial College and the Brompton, and I ran the first master's program to prepare nurses for advanced practice roles through Imperial and with the Brompton, and I could work a day a week. But he was really the first person who actually encouraged me to write, publish and do research. And we learned evidence-based practice, and this is around the time evidence-based practice became, you can see the years, when it became a thing. It was really first, launched, I guess. And so we taught it. We had to do it. In fact, the Brompton made nearly all the clinical staff do this course, from Band 5 nurse, staff nurse, to consultant. and it was a 5-day course over a few months, and seriously, about 50-60% of the staff got put on this course. It was valued by the chief exec and the director of nursing, and it made a huge difference. So This is really when the penny dropped for me, and it's only after that time that I began to think about things a bit more. So Chris Whitty was not famous when he wrote this, I can tell you. He'd been the scientific advisor for the Department of Health for many years prior to the pandemic. But he said this quote, it's really important, it's true actually. Why research is no use unless it gets to the people who need to use it, the people at the bedside who are going to apply it to their patients. That is such a classic statement, as I say, before he was famous, but now everyone knows who he is. Then I was moving from London to Liverpool because my husband lived up here, or we got married up here. So you can imagine, I'm working in Chelsea, Kensington, in London, with a bunch of Southerners and Londoners. So they tell me, right, anything north of Watford, well, that's it. Sorry, it's just, it's all about football, Oh, and it rains all the time. Oh, and by the way, they have these men that wear caps and whippets. So this is what the Londoners tell me, okay, this is what they think. Actually, by the way, I've only met one person that wears one of those work with us. So I have actually seen this person, but he didn't have a whippet. Anyway, instead, of course, I found, I live in Liverpool and it's not far from here, and I found a beautiful city. It's not what the Londoners and the Southerners think it is, but of course, this is the ongoing perception, isn't it? And as an outsider, not an English person, I can see this still exists. I came up here. I started working at Alder Hay Children's Hospital in Liverpool, John Moores. It was called a lecture practitioner role, so we worked half university, half NHS, and I ran the specialist ICU course. It was quite an easy job, meaning that I'd run a master's program, and this was not master's level, it was just a CPD course, so continuing professional development. But I was allowed to work clinically, which I loved, and I could start to do some practice development, some clinical audit, some research, and really started questioning the evidence again from my practice. And at this time, I really started the PhD part-time. I can't tell you exactly what made me start, but because I actually don't remember. But I was working full-time, and I completed this in 4 years, and it was on this topic. And this was, again, it came out of clinical practice. So we were taught when these children came in with severe brain injury, severe head injury, don't touch them. Anything you do puts the pressure inside their brain. And I thought, well, how would you know if everything we do? Because we do everything together. So how would you know? So this was effectively what I studied in my PhD. And then thinking about this, as I have been increasingly, this April in intensive care medicine, which is one of the high impact journals in the specialty, Mervyn Singer, who's a famous professor of adult intensive care medicine based at UCL, he wrote this great review about dogma in the intensive care, and I thought, yeah, this is right. His concluding statement was that dogma often dictates the management of critically ill patients. However, often underpinning evidence isn't great, and it's overinterpreted or misapplied. Again, often selective application of practice that people like. And he encouraged the critical reappraisal of the current practices, things we do that haven't got any evidence, but we still do them and we've done it for many years. And this is an example of some of these that we've done, we've looked at, because when there is no evidence, when evidence is lacking, then these historical practices they prevail, and they're often unchallenged. We've always done it this way. I've been taught to do it this way, and I've always done it this way, and no one's ever challenged what the evidence is for that. Some of these are classics, so gastric residual volume measurement, which of course I'm doing a trial on. But even attitudes towards fever. I was involved in a study by Mark Peters looking at what temperature different people treat fever. And it varied between the junior nurse, the senior nurse, the registrar and the consultant. So completely different thresholds for when, fever is treated. Intravenous maintenance fluids in children, also not based on evidence, on a formula from 1957 that none of us use. We use it and then we just take away various amounts because it doesn't work. And fasting for extubation, for taking the breathing tube out in children, a lot. So they end up fasting, meaning they don't eat food for a lot of the time. So this is really, I guess, where my research program has developed into challenging these historical care practices and trying to get evidence into practice. And the two big ones, it's not that I don't do other random things, because sometimes you end up doing random things, but really around improving nutrition in critically ill children and facilitating the timely weaning from the ventilator and preventing them failing extubation. And, you know, I've been involved in that quite a lot, I suppose. So I know what some of you might ask. You're not a dietitian, so how have you got you're a nurse, so how did you get a program of research around nutrition? Well, it started in this congress in Vilnius and Lithuania in 2015, and we had a very long bus ride every morning from the hotel to the conference. It was about 35 minutes in a bus every single day and back. And so one day, this fellow sat beside me. I vaguely knew him, but I didn't know him well. And he was in the nutrition section of this society as well. And we started talking about, you know, common practices, you know, on his ICU in Lyon in France and ours. And I just could not believe that they weren't doing this thing. They'd never done this thing, which we did religiously every 2 hours. I thought, this is, you know, madness. Well, we should do a study, right? So we did an unfunded feasibility or comparison study between the 2 units, looking at this practice to see if there any evidence for, you know, are our patients doing better because we're doing this practice? They weren't. And since that time, it started, and we've had 30 more published papers. So really, I suppose it started with a discussion at a conference, and I'll talk more about the importance of networking at conferences, because I don't think it can be underestimated. Me, being in the ICU, having clinical research practice is vital. You know, if you think about scientists, other scientists, pure scientists, they have a laboratory, they do their research. But for us, my laboratory is the intensive care unit. It's the patients in the intensive care, it's the staff, it's the service, it's everything about critical care. That is my laboratory, if you like. And anyone who's a clinical researcher, this is some very unflattering photos then during the pandemic, hideous, never mind. But this is, you know, this is my world, and this is what I have to do. And I need to have a clinical contract with effectively your lab, I suppose. So it's really important for me and any clinical researcher that we do, that we involve, because actually things change in practice really quickly, and if you sit behind a desk in academia, you don't actually know that. And it's only when you're sitting in the handover, you're like, when did we start doing this? Every Wednesday morning I ask myself this question, what happened here? So, you know, and that's when you begin to unravel this whole picture of, well, why are we doing this? You know, questions for me, clinical questions arrive from practice, and they should impact back on practice. That's my research. But as I said to you, I can't underestimate the importance of networking with your professional societies. So there are loads within anyone's specialty. For us, when I first qualified in Australia and worked at an ICU, I was in the Australian New Zealand Society of Intensive Care, but the UK one is the Paediatric Intensive Care Society, or Critical Care now, the European Society, and the World Federation. So that's a few for us. It's quite a small specialty. And really, it's through these networks that you meet people, that you do research. This is a project group that did research. I became nursing president of the European Society, but you know, I was able to visit Latvia, Riga in Latvia, for 2 days with my colleague Joseph Manning. Met people through the society to do that, and made contacts there. Shanghai, China, again, through society, through contacts that you meet at these societies. During lockdown, of course, during 2 years, we did a lot of this stuff online, and it was all, you know, on Twitter and everything, but we still did it, we still progressed. It's not as good as being face to face, but actually all these things are vitally important. They develop your leadership skills, but also they just help you to make contacts and see things from a different angle. Because, you know, in one country, in one unit, they tend to see things in the same light, I suppose, in the same way. But other people can push you outside that space. And really, all these papers alone, there's just a few, I couldn't put them all up there, they're all only possible through being involved in these networks, okay? We couldn't have done any of them without. So this is through the Paediatric Intensive Care Society, through European Society. You can see we try and actually badge the societies in them, but, you know, all done through being, meeting people, having contacts and research contacts through societies. They can't have been done any other way. Research is not one person's name on a paper anymore. I'm actually quite suspicious if I ever see that, because it's just not, that's not how we do research anymore. It's also not unidisciplinary either, it's multidisciplinary. And the other thing, so just to, in the dark green bits, I should have used different colour, just all the places I visited or work. So this is not leisure or travel or holidays. These are places I visited as either as scholarships or been invited scholar or whatever, worked on the units or done stuff. So actually I've travelled quite a lot of the world just through work, and I've seen a lot of intensive care units in my time, be they neonatal, paediatric or adult. And of course we complain about the NHS here, but I tell you, when you go to some of these countries, you've never seen anything like it in terms of poverty, and there is no comparison. So amazing opportunities really through networking through these societies. So getting back to the topic for a couple of slides. So evidence-based practice in critical care, is it still only rhetoric? Do we say we do this, but actually don't do it? Despite being effective, gold standard for safe and effective healthcare, we know from other areas that as little as 20% of effective, known to be effective treatments actually reach patients still. And this may be even less in intensive care. And the barriers for this, there's lots of time constraints. We know there are staff shortages in the NHS, but there are also knowledge deficits. There's a lack of role models to encourage and guide staff, an organisational culture that promotes adherence to historical practices, and poor clinical leadership. Because, change is threatening for people, and senior people often don't want change. Many clinical staff still don't understand or value research, I would say, and evidence-based practice. I hold this true. I still, definitely, I would say without a doubt, this is a prevailing attitude still. Yet knowledge of evidence-based practice is the strongest predictor for practicing evidence-based practice. If you don't know about it, you're not going to practice it. So that's a key thing. And clinicians don't always have the skills and the knowledge, or the willing, or the resources as well, to be able to translate research findings into clinical practice. And of course, some of them don't have the authority to do it. You do need some degree of authority to be able to do that. And changing, I think what we're dealing with now is changing healthcare professionals' behaviours remains the biggest challenge in healthcare. And this is a classic quote. A lot of universities have it up on the walls of the stairwell, actually. 3 universities I've worked in have it up. The most dangerous phrase in our language is, we've always done it this way. And if I've heard this once as a nurse, I've heard this 1,000 times in my 30-year career. Whichever way that is, the Older Hay way, the Great Ormond Street way, the whatever. You've all heard it 100 times. It's a dangerous phrase. So let's get back to our example that I used before of this study that's come out, big study, again showing evidence. There's the evidence, which showed one was more effective than the other. And yet what you've got in clinical practice is people saying, yeah, but actually I prefer X or this other practice. So really, I still think that experience is far more heavily valued in clinical care than evidence. I think we've got some way to go before we can really say that we're practicing evidence-based practice. And some of you, if you're healthcare professionals, will have seen this before. This is the research to practice pipeline, famous one. So this basically shows you that when research is published, so in academic journals, once it's published, it takes, and still this is true, on average 17 years to become embedded into routine clinical practice. And actually there was and we haven't even done this in critical care, so who knows? With the exception of the pandemic and COVID research, that was the only time in critical care where research rapidly impacted on practice. But it was an extreme situation, right? We were, all thought we were going to die or get it, or someone else was. So, there was a driven an incentive, and also some of the bureaucracy got released. But nevertheless, this is what it takes. And some work recently in cancer care showed 15 years. So this was published last year. So, there is still, I don't really think that's acceptable in 2022. We've known about this problem for a long time. Look at the year this was published. And now we're 15 years on, and we're still not using evidence in practice, and probably wasting taxpayers' monies on trials if we're not. So, getting to the end, you'll be happy to know. I'd like to think that I practice evidence-based practice in my life, not just, rhetoric. I'm a skier. as my husband and his family, and I'm sure Hugo would say that I'm just showing off there, but anyway, there we are. So I found this evidence-based review of recreational skiers, reducing risk of injury, because obviously we've all been injured a few times in this high-risk sport. So I'd like to think that, so wearing a helmet reduces your risk of serious head trauma, and I have got a helmet on, you can see that there. And it's not associated with injuries, good to know. Knee brace, you can't see it, it's under the salopet, but I ski with a knee brace and it does reduce the risk of knee injury, of which I've already had. And having your own equipment, so you can't see them, but skis, boots, having your own equipment as opposed to rental equipment reduces your risk of injury as well, because they fit better and everything like that. So I would like to think that I have, I practice this in that way as well. Coming to the last couple of slides, I wanted to thank quite a few people who have helped me and mentored me, even informally, I suppose, over the years. Some of whom are here. I did tell you, someone does actually wear a flat cap, and he is from North England, and many of us know Andy, who was the first nurse consultant in the country, actually, and helped me get the job up in Alder Hey. Jerry's now the nurse consultant in ICU at Alder Hey. So, but lots of people have helped me over the years. Paolo and Paul were my PhD supervisors, both retired now. There's a theme here, you'll see in a minute. Paolo is Professor of Computing and Mathematics at Liverpool John Moores, and Paul was an intensivist at Alder Hey. Steve Kerr was one of the intensivists at Alder Hey as well, who also retired, and he was great, very supportive of nurses and anything you wanted to do. If it made sense, he's with it. Brona and Sylvie, Brona is Professor of Critical Care in Queen's at Belfast, and Sylvie is Professor of Nursing in Lausanne in Switzerland. They're both on the call, and both have been really supportive and instrumental in helping me just navigate things, They're more experienced than me, and it's been great. I'm coming to Bernie last, okay. And then this is my first ward manager, Mary, who was Canadian-trained nurse working in that big cardiac intensive care unit. Great, she had a vision, she was fantastic. Martha Curley is Professor of Pediatric Intensive Care Nursing in the US, probably the most famous one, I'd say, in the world, and has been really, again, supportive. Jos Latour, who's on the call, really amazing professor of nursing. He's in Plymouth now, but he used to be in Rotterdam. And again, met him when I went to a travel fellowship in Rotterdam. I'd met him before through society, but really got to meet him a bit more through there. And really, just again, you could ask him anything and he would probably know the answer. He'd been there and done it. Ennerton also, who I think is on the call tonight, probably doesn't even think she's been a mentor to me, but in fact she has, how to navigate. She's Professor of Infectious Diseases at University of Liverpool. And, really, if you didn't know what to do, you could ask Ennerton, and again, she would tell you, I think this is what you should do, or it's not acceptable that they do this, or they treat you this way, or whatever. So she was great. Ian had a whole slide to himself. I've talked about Ian. Matthew Peake, who was the former director of research at Alder Hey, also retired, was great. Again, really supportive. I met him from the minute, really the first week I worked at Alder Hey, really supportive of any research done by non-medics as well. Fred, I've talked about, this is the Alder Hey team, some of whom are retired, and there's more of the Alder Hey team at a conference, the advanced nurse practitioners on the ICU, as Andy with his little harem of nurse practitioners there. And Bernie, I wanted to mention Bernie last. So Bernie I've worked with since when I first came up here, I think in the first maybe couple of years, I think the Children's Nursing Research Unit, Bernie opened at Alder Hey. And she wasn't my boss, I worked at John Moores, but she really guided myself and Lucy actually, and others in this really supportive environment, virtual environment. We did actually meet. And then she became my boss at UCLan. I went to UCLan to work with Bernie because she was there. And then now I'm sharing office with Bernie, but she's part retired, so still working. So these are some of the people who've really helped and mentored me over the years. And finally, of course, special thanks to my husband Hugo, who probably kills me for that photo. That was walking Chamonix a couple of years ago. My parents, who can't be here, and they're on a cruise somewhere in the Middle East, I think, and Hugo's mum, who sadly passed away 4 years ago, who painstakingly, not being a healthcare professional or an academic, painstakingly read every word of my thesis, which took her about a month, and corrected all the grammar and English, things. So I'd like to leave you with this, really. This is published in the British Medical Journal a couple of years ago now. Alternatives, evidence-based medicine. You may have seen this already. I particularly like the first one, which I think is pretty common, actually. And I particularly think the last one is nice. I don't think we have this much here. I think we work in the US, yes. The wrong test is one in order. I don't think that's the case here, but I think that's a funny thing. And finally, just with that, what do ICU nurses do? It's obviously an American thing, but people's perception of what you do varies depending on who it is that's thinking of these things. And that's all. Thank you.